Sabin's social and behavioral research grant partners sought to understand and address barriers related to vaccine acceptance and demand within their specific communities in low and middle income country settings. From vaccine equity to vaccine access, from vaccination service delivery to decision making. Piloting and evaluating community co-designed interventions and sharing those findings both with the public and key stakeholders is of paramount importance in order to address community-level problems with community-tailored solutions. Now that our partners have conducted their co-designed research, what are the key findings that are emerging from these communities?
Were these findings surprising for me? No, especially that of, the concerns people have about COVID vaccine side effects, efficacy, and safety. I mean, there's been a lot of surveys that's been done in Nigeria, and we've been seeing these similar findings since 2021 when the vaccine was introduced in Nigeria. However, the only finding that I didn't expect to see was the vaccine unavailability. We found that vaccination acceptance rates was higher in the healthcare workers compared to the eligible adults. However, among the unvaccinated, healthcare workers and adults, vaccine hesitancy rate was similar at 34%. Because, like I mentioned earlier, we use the WHO BESD framework, and along the BESD framework, the main barriers to non-vaccination were practical related, right? So in that practical domain, I think the top three were lack of knowledge on where to get vaccinated, vaccine not being offered yet, vaccine unavailability. And then and this was followed by thoughts and feeling, where there were concerns about, vaccine safety, efficacy, side effects. And then on the social processes parts of the framework, the most mentioned was distrust in government. Our qualitative insights also collaborated with these survey findings, and misinformation, conspiracy theories about COVID and COVID vaccine, gender, family norms, distrust in government affected their motivation to get vaccinated. And we also saw that, long waiting times, participants mentioned that long waiting times and vaccine unavailability also affected, their motivation, to come for subsequent doses.
So some of the things we're finding are that not many people are aware of the need to go back for something called a booster dose. They don't know what a booster dose is. And so that's been an interesting finding. So I think that this research can shed light about the whole process and the decision-making process, and that information will not only help the current vaccine program in terms of getting more people to come get their first dose, but also in terms of having people come back for subsequent doses to ensure full protection against COVID.
One of the things that we found was the value that healthcare workers and providers found in finding key stakeholders in the community and creating collaborations in the community. So whether it's chiefs or councils, religious leaders, influential mobilizers, social mobilizers in the community, all of those places are important. So another key takeaway is the importance of collaborating across various stakeholders. The government needs to interact with the healthcare system. The healthcare system needs to interact with the community. That through the collaboration of these trusted sources, that we would be able to really effectively, disseminate a consistent, coherent message, and then also leverage the resources and influence of those various individuals and stakeholders to ultimately support the health of the community. We found that, for community members, they really turn to healthcare providers as a really important source of information. And so we felt like it would be important to really make sure that our healthcare workers were equipped to be able to, rise to the level of value that the community saw them in terms of being a trusted agent.
The work in our research shows that people from the communities that are under-vaccinated are willing to take the vaccines, but there is a lot of mistrust, misinformation, and they are hesitant to come to the same health system that has given them traumatic experiences in the past. When the health system has not been equitable to them, safe for them, why would they come forward to take something from the same health system?
In our qualitative phase, we found that there was hesitancy in receiving COVID-19 vaccine among MSM living with HIV in the beginning of the vaccine rollout due to concerns of their health condition, side effects, interaction with their antiviral medicine, and especially the ability to choose the type of vaccine. This correlates with the viewpoint shared by the HIV care providers that people living with HIV would seek advice from the HIV providers whether they could receive the COVID-19 vaccine and the safety of the vaccine, and they also shared their concerns if they have to disclose their HIV status at the vaccination center. The results from our in-depth interviews with the participants reported that MSM living with HIV had communication with their HIV providers such as doctors, nurses, and community workers prior to making decisions for receiving COVID-19 vaccine.
Our partners saw suboptimal vaccine acceptance, demand, and uptake in their respective communities, involved key community stakeholders in their research design, and have now garnered a deeper understanding of the key drivers of these issues and tailored strategies to combat them. What do we do with this information in order to address these issues while placing the needs of the community first and foremost? Where do we go from here? Up next, we look at the way forward. Our partners take their findings a step further, providing recommendations for key stakeholders in policy, programs, and practice.